My second presentation is related to palliative care and market failure. I would like to begin this presentation by quoting a Tirukural, which goes like this: Arivinal aguvadundo, pirivinnoi thannoi pol potran kadai, which states that what is the purpose of having a knowledge if we can't empathize with the people who are actually suffering. Palliative care and market failure, the theme was regarding the out-of-pocket health expenditure, the minimization of it through palliative care in non-cancer patients. The background is India being a home of 1/6 of the global population, which states that there is a serious burden on serious health-related illnesses as well as terminal illnesses. This exposes the need for a robust palliative care services to alleviate the sufferings and to improve the quality of life of the people. However, a report published by the Federation of Indian Chamber of Commerce and Industries states that only 1 to 2% of the population who actually needs the palliative care have access to it. So this shows the miserable state of a palliative care in Indian healthcare system. Moreover, the neglect of palliative care and focusing much on the curative care aspects has resulted in a huge out-of-pocket expenditure, which led to dragging millions below the poverty line. So this is the same definition from my previous slide. Okay, the palliative care, as defined by Dame Cicely Sanders, who is the mother of palliative care and the founder of St. Christopher's Hospice, she has stated palliative care is not about adding days to the life, but about adding life to those days. According to World Health Organization, palliative care means a holistic approach to improve the quality of life of the people suffering from serious health-related illness. However, there is a common misconception which is prevalent among the public as well as among the doctors that palliative care is meant only for terminal stage cancer patients. This misconception hinders the accessibility of the palliative care to millions of genuine non-cancer patients. Early delivery of the palliative care services has the potential to reduce this unnecessary out-of-pocket expenditure. See, this data is being obtained from the World Health Organization statistical report in palliative care. From this, we can see that cancer contributes only to the 34%. Cardiovascular diseases contribute to 38.5%. Chronic respiratory diseases, COPD, emphysema, these contribute to 20%. Diabetes contribute to 4.6%, AIDS to 5.3%. The problem is we are totally neglecting these contributors. Like they contribute to the huge amount that 66% of the non-cancer patients, non-cancer causes are the patients who are in need for a genuine palliative care. So next, coming to the issue of market failure. Market failure refers to a phenomena where the resources are not efficiently allocated, which result in a cause of a net economic losses. Market failure could be due to multiple causes. One could be due to a market power, that is a monopoly. Second one could be due to information asymmetry. Third one due to externalities, and finally the public goods. The relationship between the palliative care and market failure lies in terms of information asymmetry. First one is with respect to adverse selection of curative care over palliative care. Because the patients are not having a sufficient guidance and lack of awareness among themselves will enable them to choose, will force them to choose the curative care over the palliative care. Second one with respect to the principal agent problem, wherein the patient is the principal and doctor is the agent. But in the hope or in the hope of the advancements in healthcare sector, the doctor always prefer to choose the curative care because still there are some possibility of saving the life. So they will always go with the curative care. But the problem with the curative care is that for many of the terminal illnesses, this curative care itself reduces or worsens the quality of life of the patients. So existing policy interventions are the National Program for Palliative Care. In 2012, Ministry of Health and Family Welfare formed an expert group to suggest a report on palliative care, and it was named as Proposal of Strategies for Palliative Care in India. In India, the palliative care is subsumed under the National AIDS Control Program and the National Program for Prevention and Control of Cancer, Diabetes and Cardiovascular Disease and Stroke. With respect to state-specific policies, many states don't have a state-specific palliative care policy, but Kerala is the first state to have a specific state-specific palliative care policy. The Calicut model of this palliative care delivery has been applauded by the World Health Organization for its affordability and quality. And it was also praised by the Economics Intelligence Unit in their quality of death report. So issues in the existing policies, the first issue is the no budgetary allocation. There is no dedicated budgetary allocation for this palliative care program in India. Second one is the information asymmetry, which I have dealt earlier. Third one is the negligence towards non-cancer patients. Negligence on the part of the states, because majority of the states don't have their state-specific palliative care policy. Then geographic disparity in terms of urban-rural divide in accessibility to palliative care services. The policy recommendations are, first, we should have a dedicated national and state-wise palliative care policy, catering to the needs of region-specific needs and giving adequate importance to both the cancer as well as non-cancer patients, along with appropriate budgetary allocation. Second one, with respect to addressing the information asymmetry, this can be done through awareness campaigns, information dissemination through media like newspapers, televisions, posters, and workshops. Moreover, there is also a need to educate doctors, because a survey conducted by Palliative India states that many of the doctors are not even aware of the palliative care services, that they are thinking that it's only meant for the terminal stage cancer patients. Third one is with respect to ensuring efficiency without compromising the equity. This can be fulfilled through the community-based palliative care management movement. There is a movement called Neighborhood Network of Palliative Care. It is a joint venture between the NGOs as well as the community health workers as well as health volunteers to promote a decentralized mechanism for providing palliative care services to the patients who are actually in need of it. Third one, reducing the government fiscal burden by promoting the engagement of cooperatives in the development of pain clinics and model palliative care and pain clinics. This has the potential to address the rural-urban disparity. Finally, the government incentivized business process innovation, which I have presented earlier. This is the expected benefit and the externality. Based on the altruistic social preference model of behavioral economics in health policy perspective, the major reason or aim for mainstreaming palliative care services is to improve the quality of life of the patients suffering from serious health-related illnesses. Because it was envisaged in the Menaka Gandhi case that Supreme Court has stated that the right to life doesn't mean a mere animal existence. It means a life with a dignified life in a dignified manner. That is a dignified quality of life. To ensure this, there is a need to have how the right to life is dignified, the right to death should also be dignified. With the above mentioned policy interventions, it can be expected that the palliative care intervention at right time has the potential to reduce unnecessary hospitalizations, improves the quality of life of the patient suffering from serious health-related illness. It also has an important positive externality in terms of reducing the unnecessary out-of-pocket expenditure. If there is a positive externality and that is being underproduced in the market, it has to be supported by the government through government interventions, which can be through the government incentivized business process innovations. Thank you all.
Thank you, Jyothi has again highlighted a sort of important aspect which is about palliative care. He talks about market sort of, especially regard to market failure. I think it's also important to look at what dimensions exist at this point in terms of Government of India interventions also with regard to end-of-life care, right?